The next exam is our knee exam. Much like we did with the ankle, you want to follow your inspection first. So looking at the knee, we often want to inspect for any signs of swelling, deformity, or even looking for an effusion, as this can sometimes be visualized. Following inspection, I then like to do my palpation. The main thing that you palpate for at the knee is any effusion, seeing if you can feel that fluid on the knee both passively up and down like this, or you can even do your ballottement test where you're bouncing the kneecap, seeing if you can feel that fluid wave. There can also be a lot of soft tissue swelling, and this can give you a chance to figure out whether it's an effusion or soft tissue injury. Once we've done that, the knee is a joint that I typically only do passive range of motion testing on, so as I bring them up, I like to see where their flexion goes to and then ensure that they can get to full extension. Once we've moved past that, I then test their strength testing and also do a straight leg raise, which can make sure that their quad tendon and patellar tendon, or what we call their extensor mechanism, is intact. So I'll often have the patient bring their foot up, make a good muscle here with their quad, and then do a straight leg raise to see how that functions. I'll then do a little resisted motion just to make sure. I then like to bend them at the knee and bring them up to the 90-90 position. From here, I like to test the knee a little bit further, having them push up towards the ceiling, seeing how their extension is functioning, and then have them pull their heel back towards them to see how their flexion is, making sure that they have 5 out of 5 strength. The first specialized test that I like to do is called the Lachman's test. This tests their anterior cruciate ligament. Oftentimes it's best to have the patient as relaxed as possible. With your top hand, you want to stabilize the femur. Your bottom hand is then going to translate their tibia, trying to feel for any signs of laxity or instability. A no endpoint is concerned for a tear of their ACL. If the patient has extremely large legs or is difficult to get a good feel for, you can use your knee as a bolster to then kind of help relax that. Your top hand then stabilizes the femur, and the test is repeated in the same fashion. Once you've tested that, you then like to test their medial collateral ligament. This is done with a valgus stress test. What we like to do is lock them out at 0 degrees, stressing that with a medial force from your top hand and a lateral force from your bottom hand. This is done at both 0 degrees and 30 degrees of flexion to look for any signs of instability or laxity. The same test is then repeated for the lateral collateral ligament, both at 0 degrees and at 30 degrees. However, you are now pushing in the opposite direction with your more proximal hand pushing in a lateral fashion and your distal hand pushing in a medial fashion to stress that lateral collateral ligament. Once you've tested their ligaments, I like to bring them up and set them into our anterior and posterior drawer position. I like to stabilize their foot by sitting on it. This helps the patient relax, as it's key to get the hamstrings to relax to get a good test. Once you've got them in a relaxed position, you want to make sure that their tibial condyles their tibial plateau matches up with the femur, because you can be fooled if they're in a sag position from a torn or ruptured ligament. Making sure that that is level, you want to then do a quick jerk anteriorly, making sure you feel an endpoint. That would be your anterior drawer test for the ACL. The posterior drawer test is done in a similar fashion, but once you pull anterior, you then give a posterior force to make sure there's an endpoint with that PCL ligament. The last portion of the exam is then testing the meniscus. What we like to do for the meniscus is to bring them up into full flexion, seeing if this recreates any pain. This is setting them up for the McMurray's test. Oftentimes this test can be positive with many other things, so I like to see if it causes pain just in full flexion. If that's okay, I then, using my distal hand on their heel, like to do a small rotational motion, seeing if you can catch the posterior aspect of the lateral meniscus and the medial meniscus. If no pain or popping is elicited at this point, I then take them into a valgus stress or a varus stress, repeating multiple ranges of motion and directions, trying to elicit a positive McMurray's for their meniscus. The last test is then done standing, which is done for our meniscus. This is called Thessaly's test. What we do is have the patient stand up, having them stand on the injured leg, We then have them bend about 30 degrees, and we have them twist from side to side, assisting the patient with your hands to make sure they don't fall. But this torsional force on the meniscus can often elicit pain or even a painful pop, which would be a positive Thessaly's test.